This is the 7th webinar. We are going to conduct every month on first day. So today's webinar mainly to commemorate World Hepatitis Day and topic about the stem cell therapy or regenerative medicine. So we have a stalwart speakers from the Department of Gastroenterology and Hepatology and the stem cell experts here. So we are going to enjoy this program. So this is the brief program agenda. Maybe start with the IMA and physician prayer. For that, I request Dr. Adar Sendil Kumar for the physician prayer. Sendil Kumar, are you there? Okay, no problem. Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me a singleness of purpose, strength to lift at least a part of the burden of my suffering fellow man, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. With this, I welcome our chairman, Dr. Rajesh Babu sir, for the welcome address. Dr. Rajesh Babu sir is a senior consultant, neurosurgeon, and head of the department in Ganga Hospital, Coimbatore. Dr. Rajesh Babu sir is the former president of IMA Coimbatore, and currently serves as chairman organization committee as well as the IMA Academy of Medical Specialty. Over to Dr. Rajesh Babu sir for welcome address.
Good afternoon, everyone. I welcome you all for this CME, which is conducted for the 7th consecutive month from AMS. At the outset, I thank our President of Indian Medical Association, Dr. Abullah sir, for joining this program, and the Secretary sir, Dr. Karthik Prabhu sir, and Dr. Gauri Sankar sir, the Treasurer, and the President-elect sir, Dr. Sengutuvan and Dr. Sridhar sir, this month. So I welcome you one and all for the program. Thank you.
Thank you, Chairman sir. May I request our State President of IMA TNSB, Dr. K.M. Abul Hasan sir, for the presidential address. Over to Abul sir.
Thank you, Dr. Jayaraman, respected office bearers of IMA TNSB, including our President-elect, Dr. Sengutuvan, Dr. Sridhar, Secretary, Dr. Karthik, Finance Secretary, Dr. Gauri, and the office bearers of AMS, Dr. Sendil, Dr. Jayaraman, and Dr. Rajesh. I congratulate all of you for organizing this wonderful scientific program today, marking World Hepatitis Day. And also thank our speakers for having accepted our invitation from AMS, Dr. Arun Prakash, Dr. Porsevi, Dr. Rajkumar, and Dr. Ravi, all the faculties who are going to speak in today's AMS webinar. And I feel this is a very, the topics are very apt and timely. And I think the stem cell therapy is increasingly prevalent. And I know Dr. Ravi is doing lots of work in this field for quite some time. So I think the delegates will be immensely benefited from today's speeches. And I wish them all the very best. And I once again thank the organizer for giving me this opportunity. Over to you, Dr. Jairam.
Thank you very much, sir. Thank you, President, sir. Now I'll give my secretary's report of our IMA AMS. So this is our team of IMA AMS, Academy of Medical Specialties. Dr. Rajesh Babu sir is the chairman and the secretary. Dr. Adar Sendil Kumar is the joint secretary of this AMS. So we have two eminent important topic. One is the World Hepatitis Day. So for which we have a moderator, Dr. S. Arul Prakash. Arul Prakash is senior consultant and clinical lead in gastroenterology and hepatology department of in MGM Healthcare, Chennai. So sir is the wonderful speaker, orator, and one of the clinical lead in MGM Healthcare in the department of gastroenterology and hepatology. I request Dr. Arul Prakash sir, please take over and start introducing the topic and the speaker introduction. Over to Dr. Arul Prakash sir.
Thank you, sir. Thank you, sir.
Welcome.
Can you hear me, sir?
Yes, sir. Yes, sir.
Yeah, it's a It's a pleasant afternoon. It's an opportunity which I'm longing for, and I'm very much thankful to the organizing secretary, president, chairman, and office bearers of IMA and AMS to conduct such fruitful knowledge exchange program. I'm very much pleased to understand like we are having this every month. This is the first time I'm just attending. So I'm really thankful to be part of this evening CME program. So coming to the topic proper, as clinicians, we all day in and day out, we would have been seeing patients with hepatitis. And, our senior colleagues, friends and junior colleagues would have seen how hepatitis has evolved in these long days. And when we call hepatitis, there are two demons probably, that's hepatitis B and C, which has been a challenge for mankind, not only in our part, like all over the world. There are update in managing these patients have changed a lot in these years. You know that hepatitis B, it's a dreadful disease which causes liver cirrhosis and hepatocellular carcinoma in a longer run. And you have hepatitis C also, which is bloodborne and transfusion related, or it can spread through sharing needles with drug abusers. That can also cause liver cirrhosis and HCC. These two viral disease of hepatitis can cause a lot of morbidity and mortality in our population. So there are beautiful update on hepatitis C medicines, because previously used to spend lakhs in treatment of hepatitis C, but nowadays there are oral tablets which is available very, very much affordable, and our government is also sponsoring that to the people who are suffering from hepatitis C. Of course, hepatitis B is little complicated. We are also stuck up with hepatitis B. And to elaborate on this, I would like to invite Dr. Porsevi. She's a senior consultant, gastroenterologist and hepatologist from Apollo Greens Road, Chennai. She's an apt person to discuss upon what has been an update in management of viral hepatitis. So she'll be taking around through the updates shortly. May I invite Dr. Porsevi? And after the end of the talk, probably, you can raise the questions and we can get the doubts cleared from Madam. And I'll coordinate for that. Thank you. I invite Dr. Porsevi to present.
And did a Master of Surgery in Orthopedics from the Dr. MGR Medical University and in the Madras Medical College. And Sir is a senior orthopedic consultant and director of Maruti Hospital, Trichy. And he is a well-versed in, he is a life member of Indian Medical Association since 1987, life member of Indian Orthopedic Surgeon, and very much interested. And he has done a lot of work on stem cell therapy, that is a regenerative medicine in rheumatology conditions and degenerative joint diseases, etc. And Sir is set up well-versed regenerative medicine center in Trichy. So the lot of paper presentation, national, regional level, and international level, a lot of awards he has acclaimed. So with this few introduction, may I request Dr. Ravi sir to present the topic on Indian government DCGI FDA approved stem cell therapies, present, past, and future. Over to Dr. Ravi sir.
Thank you. Thank you, sir. Thank you, Dr. Jayaraman, Secretary, Dr. Rajesh Babu, as well as the Dr. Adar Sendil Kumar, who are doing an excellent job in this IMA AMS wing. Today, I am really blessed to have got this opportunity to present this new topic. This is a new age topic. Stem cell therapies are slowly getting approved throughout the world. And you will be surprised that happily you will be surprised, you will be happy and surprised to know that India is really leading in this field of therapy. So first, who should listen to this talk? If you are a young doctor, you will need this for your practice. If you are an old doctor, you will need this for your own health and family health. So similarly, scientists are also involved in this field of stem cell therapy, and young scientists do it for their PhD, whereas the old will need it for their own health and family, because regenerative medicine is predominantly treating the chronic diseases and geriatric diseases. So it will be very interesting to know about these things. the first point which I want to emphasize is whether stem cell therapy is approved in India, because many people, many doctors, many scientists and public still are not sure whether stem cell therapy is approved in India. And if somebody says, I have got stem cell therapy, they have a doubt whether it was an approved therapy or unapproved therapy. But stem cell therapy is approved in India since the year 2017. So the first approval for this mesenchymal stem cell therapy came in 2017. And there are a lot of pioneers in this field of stem cell therapy and regenerative medicine. I have mentioned, except the first one, Dr. Philip Hernigo, all the others are from India. And you can see, and most of them are from Tamil Nadu. So you can see that many of these pioneers, they have toiled for decades. And what is the end result? The end result is that these people's work has been already approved by the Indian government, and these treatments are now available for our patients. For the work of Dr. Philip Hernigo in orthopedics, already stem cell therapy in orthopedics and for osteoarthritis is approved. Similarly, Dr. Rajkumar, our own vascular surgeon from both Stanley, and he retired as HOD of MMC. He was the principal investigator for stem cell therapy for critical ischemia, and now the product is available since 2020. Similarly, now our Dr. Namita Rajkumar madam, so she is actually she was the HOD as well as the director of the regional eye hospital EGMOR, and they have been doing limbal stem cell therapy for more than 2 decades. And limbal stem cell therapy is again one of the approved stem cell therapies in India. Dr. K.M. Cherian, you all know, has been doing a lot of work on stem cell therapy for cardiac diseases, but so far it has not been approved. Similarly, Dr. Anil Bansali from Chandigarh, PGI Chandigarh, he is doing work on diabetes treated with stem cell therapy, and he has conducted clinical trials, and it is yet to be approved. And in our own Stanley Medical College, we have the pioneers, Dr. Rosie Vanilla and Dr. Sekunda Anand, who is now heading the Department of Regenerative Medicine, and Dr. Rosie Vanilla, and has been in the forefront of establishing a stem cell lab for liver disease. So probably in another few years, when liver disease gets approval for stem cell therapy, it is because of the work of our people like Dr. Rosie Vanilla, Dr. Sekunda, Dr. Jashwant, and all the other people who worked in Stanley Medical College. So before going into the topic, the first point we have to get established is the principles in medical ethics, because stem cell therapy involves a lot of ethical concerns. So the main principle is non-maleficence. So we do not want to harm anybody, and the principle of beneficence, autonomy, veracity, and confidentiality is really the cornerstone, because it is important that whatever the modality is used, it has to be verified and applied with a social responsibility and justice. We have many rare diseases, we have many genetic diseases for which there is no treatment today. So people are dying because of many of these diseases, and it is our social responsibility to bring out some ethical treatments which should benefit all these people. And regarding the legal and regulatory requirements, so we can take the stem cells from patient's own body, that is autologous, and we can also take cells from another person, that is called allogenic. So if we take stem cells from patient's own body, culture it for 3 weeks, then it is classified as a drug. So it will need a approval from the drug controller. Similarly, when we take stem cells from another person and then culture it, make it into millions, and then give it for a patient for treatment, then again it is needed to have the DCGI approval. So these are called more than minimal manipulation, and they are coming under the category of drugs. And there are few licensing procedures for these stem cell therapies. I am just putting out these in case for somebody who wants to know about the legal requirements for stem cell therapy. So straight away going to the topic, I am just showing some of the approved allogenic stem cell therapies, gene therapy, as well as CAR T cell therapy. So I am just holding in my hand a bottle. So this is a empty bottle after using stem cells for osteoarthritis. This one is called stem 1. This contains 25 million stem cells for osteoarthritis. It's an empty vial which I have already used for another patient. So the other one which I am holding now is a pouch, and this also already used it. This is an empty pouch. It will come with 15 ml containing 150 million to 200 million stem cells, and this product is called regenerative. This is stem cell therapy for critical limb ischemia, and this is another product which is called VC Growth. This is actually for skin regeneration. So I am just showing these products because, as I told, India is the leader in this field of stem cell therapy. You can see in the screen already there are 7 stem cell therapy products which are approved. Since 22 August 2022, we have for osteoarthritis. From 21, we have for Burgess disease, for the CLI and PAD. Similarly, for skin regeneration, hair regeneration, and under eye dark circle, we have stem cell condition medium, all from one single company called Stempeutics. It was this company, Stempeutics, which is a part of Manipal University, who did all this research for more than 20 years, and they have convinced the drug controller by doing the necessary animal trial, the human trial, phase 1, phase 2, phase 3, and they have come out with these products. But even before in 2014, the Reliance had come out with autologous limbal stem cell product for corneal blindness. So in fact, the leaders, the specialists who have guided all of us are the ophthalmologists. So the ophthalmologists were the first people to detect that stem cells are available in every organ. In the eye, they found the stem cells at the limbus. Limbus is the corneoscleral junction, so where they found the stem cells, and they have used that for curing blindness, which is caused by the corneal opacity. So cell is actually when you take a small biopsy from the limbus of a patient with corneal blindness on one eye. From the other healthy eye, you can take a small biopsy from the limbus, send it to cell, and within 3 weeks, they will culture the stem cells and send minimum 50 million cells on amniotic membrane, which you can apply over the eye and regain some vision. So as I told, India has been one of the pioneers in using these stem cells, and till today, millions of ophthalmology patients, millions of corneal blind patients have been treated with limbal stem cell therapy, and it is one of the most successful stem cell therapies ever. And coming to the latest, Zolgensma is actually for spinal muscular atrophy, another very rare disease, but there is no treatment for this spinal muscular atrophy because it is a purely genetic disease. So the first genetic disease to be approved in USA for SMA, spinal muscular atrophy, is this Zolgensma, though it is not got the direct approval in India. Because it is approved in US FDA, it can be imported in India, and within these 2 to 3 years, more than 10 children have been given this gene therapy, which is a form of cure for spinal muscular atrophy. Similarly, immune cell therapy, which is actually for cancers. When patients develop cancer, the new form of therapy, apart from chemotherapy, radiotherapy, and surgery, now immunotherapy is the fourth pillar of the treatment for cancer. And the T cells, which are genetically engineered to form these CAR T cells, they are approved for blood cancer. And in India, one product from ImmunoAct. ImmunoAct is a company in Mumbai. So they have got approval for one of the immune therapies in India from October 2023. So I have just listed some of these approved therapies so that all the doctors become aware, and the patients can get the benefit once the awareness spreads. So there are specific indications. Not all cases will be successful with stem cell therapy. For example, in my field of orthopedics, though it is approved for osteoarthritis, the approval is only for stage 2 and stage 3 disease where there is no deformity. So similarly, in Berger's disease, in every other indication, there are specific stages where you can use the stem cell therapy, and it is not like a blanket approval. And these are again some of the products for regeneration of hair, skin regeneration, and under eye dark circle. And three more products from Regrow Biosciences. This is also one of the Indian companies in Pune. So whenever there is a avascular necrosis of the bone of the head of the femur, what we can do now is take a biopsy from a healthy bone and send it to this company Regrow, and in their FDA approved lab, they will grow the stem cells, and after 3 weeks they will send to us 48 million stem cells, which we can inject into the avascular area. Similarly, when there is a cartilage damage because of some sports injury, when volleyball players, basketball players, and other football players, they have the cartilage injury, and in those cases, in young patients, when there is a specific area of cartilage which is damaged, then it can be regenerated by sending a small biopsy from a non-affected area to this company. They will grow the cartilage and send it back to us, which we can inject into the knee joint. Similarly, for urethral stricture again, urethral stricture is one of the vexing problems for the urologists, and they have been doing procedures, surgeries, dilatation, but still it is a unsolved problem in many patients. So again, if you take a biopsy from the oral mucosa, you can take a biopsy, small biopsy from oral mucosa, send it to this company, Regrow Biosciences in Pune, and they will grow that oral mucosal cells into a sheet and then and send it back to us, which can be injected into the stricture area if it is less than 4 centimeter. So as I told you, it is not for all strictures of all lengths. It is restricted to urethral stricture less than 4 centimeter. So in every indication, there is a specific group of patients who are approved for these conditions. So I have just posted the approval letters by the drug controller. You can see the date of approval 2017, 2020, and 2022 for the different indications. So worldwide, apart from India, what are the other stem cell therapies which are approved? In Japan, for Crohn's disease with complex perianal fistula, the stem cells derived from fat is used to heal the multiple recurrent perianal fistula. Similarly, when patients with blood cancer are treated with bone marrow transplant, if there is a mismatch, then they develop graft versus host disease, and many patients die if steroids are not successful in preventing it. So in such cases, steroid-resistant GVHD stem cell therapy is approved. Similarly, the first time in the world, you can see for Parkinsonism. Parkinsonism is the first neuro disease to be approved in the world for stem cell therapy, where 5 doses are given. Each dose will contain 200 million stem cells, out of which 50 million will be given intrathecal and 150 million stem cells will be given intravenous. All and these 5 doses are given every month, one dose every month for 5 months. So this approval came in November 2023. So similarly, for cornea and for Crohn's disease, Europe it is approved. South Korea, umbilical cords derived stem cell therapy is approved for osteoarthritis. So I've just listed out some of the treatments, some of the stem cell therapies which are approved, which patients can get utilized provided they fall into a category for which they are approved. Just a brief explanation about this STEM 1, which is for osteoarthritis. Since I am an orthopedic surgeon, I will start with this stem 1. This is actually a allogenic mesenchymal stem cells, which means they are taken from 3 young adults. So these stem cells, like a blood donor, they took from young adults who are otherwise healthy adults. From their bone marrow, they have pooled whatever the stem cells they have taken from 3 people, they have pooled together and they have created a stem cell bank. And from that stem cell bank, they can create 1 million doses. And they have studied, they have conducted a strong 1-year clinical data from the study, which is a large phase 3 trial in India to support the efficacy and safety of these treatments, and at least 1 year of pain relief and stiffness reduction and improvement in physical function. And it is the only available treatment that maintains the cartilage quality and volume for over 1 year. And there are minimal side effects compared with what is normally seen in other treatments. And as I told, it is only for grade 2, grade 3. In grade 4 of osteoarthritis, usually there is a gross deformity of the knee joint. The knee joint will be deformed. There will be varus deformity or valgus deformity. And in such cases, stem cell therapies cannot bring back the normal alignment. So we have to do surgery. So the role for total knee replacement, the role for osteotomies in surgery for osteoarthritis is still there. Stem cell therapy is only used in selective cases. So as I told, it is taken from 3 young adults and it is pooled. It is usually taken from the bone marrow. It is taken from the posterior iliac crest or from the anterior iliac crest. And when these stem cells are taken and in the lab, they have got a very good GMP lab at Manipal, which belongs to the Manipal University. And there they do all this culture, and then they receive the drug controller approval for using these cells in indications like CLI as well as osteoarthritis. And already 2 other indications are getting the human trial ongoing. So for any diabetic foot ulcer, the stem cell therapy, the large study is phase 3 study is over, unblinding is also over, and they are just waiting for the drug controller to give the approval. Probably in another 2-3 months, we will be adding the 8th indication, that is stem cell therapy for diabetic foot ulcers, non-healing, particularly non-healing foot ulcers. Similarly, for perianal fistula in Crohn's disease, which is a autoimmune disease. So in New Delhi, in AIIMS New Delhi, already the phase 2 trial has been completed, and they are going in for the phase 3 trial, and within probably 1 year or 2 years, they will come out with another product which will be useful for a Crohn's disease. So I will just show some of the cases where we have got the results. So in this talk, we will be also seeing some of the results of cases done, which is a proof what the government says by way of approval, and what the scientific academic forum says by way of publications. That also we will be seeing, but we will also be seeing some of the results. So this is actually the case which I did in 2012, where there was a narrowing of the joint space and severe pain on the lateral side of the knee joint, which after injection of autologous stem cells, you can see that there is a slight increase in the cartilage height, which can be demonstrated on the 7th month post-op. So similarly, this is another case where a 54 years old female with osteoarthritis using autologous bone marrow. So in these cases, till we got this stem 1 product in 2022, we were doing autologous. Now the patients have got 2 choices. If the patient has got osteoarthritis, we can either take stem cells from his own bone marrow, or we can use this stem 1 product, which is allogenic. When usually the patients are very old, like more than 80 years, 85 years, when their own bone marrow contains very little cells, then we can go for allogenic source, like this is the ready-made stem cells. Whereas if the patient is around 55, 60, 65, their own bone marrow is very rich in stem cells. So we can take from their own bone marrow and then inject the stem cells into the knee joint. And here again, you can see that the joint space, which is very much narrowed on the medial side, there is a little improvement in the regeneration. So this regeneration of cartilage cannot happen with drugs. There are no drugs which can regenerate. We injected steroids for a very long time, but it did not regenerate. We were injecting other substances like hyaluronic acid also, so that will also not regenerate. So when the regeneration is possible only with stem cell therapy. So this is again another 56-year-old female of osteoarthritis, where on both sides you can see the right side as well as the left side narrowing, and here you can see right side and left side after injection. There is a slight increase in the cartilage height. And how long the effect lasts? Suppose we give a stem cell therapy, patients want to know how long does the effect of one single injection last. So here you can see that it lasted for 4 years in this particular patient, who is again a 54-year-old female with osteoarthritis. Using her own bone marrow, we had injected, and you can see after 30 months, you can see the cartilage height is improved, and it is still maintaining at the 48th month. So at minimum 4 to 5 years, if the patient does not put on weight, the patient should be ready to cooperate with us in reducing the body weight and then do regular exercises. Then the effect will be lasting for a longer time. And here again, some of the other cases not done by me, but from the literature what I have taken for patellar osteoarthritis, with the chondromalacia patella, when you can see there is an increase in the cartilage height when compared to the pre-op, the post-op. After 32 months also, you can see that the cartilage height of the patellofemoral joint is very much increased. So this is again, now MRI is a very good tool with which we can measure, like ultrasound, we can do the measurements and see whether there is an increase or decrease in the cartilage height. And in osteoarthritis, it is not only the cartilage. So most of the times in these patients, there is also partial tear of the cruciate ligament. There will be partial tear in the menisci. There will be tear in the medial or lateral collateral ligaments. So the many structures, soft tissue structures inside the joint are all damaged, and stem cells can regenerate every tissue which is damaged. So here you can see a partial tear of the ACL which has been treated, and post-op 1 year you can see the partial tear which is healed, ACL tear before treatment, and here after 1 year you can see the complete healing of the partial ACL tear. And in MRI, you have got very good tools, some artificial intelligence tools with which they can measure the intensity of the soft tissues, and then they draw this histogram. These histograms can show whether the healing is complete or whether it is how much improved when compared to the previous. So here you can see that in partial ACL rupture, pre and post bone marrow derived stem cells, the MRI showing the improvement in the quality of the this is the quality of the ACL, the cruciate ligament. So now we need not go for a biopsy. So no need to take a biopsy to show that there has been an improvement in the quality of the cartilage, and we are getting 3 Tesla MRIs, which are much more powerful, which reveal much more clarity in their pictures to show the post-treatment improvements. So again, these are some of these MRI images using autologous stem cell therapy as well as platelet-rich plasma for partial. So I am just putting out, again, this is for meniscus. You can see this is the meniscal lesion before the injection. There is a tear in the meniscus, which after injection, you can see that the tear has healed well. This is 6 months after injection. So this is the publication which was submitted by the Manipal group, where they have done a double-blind randomized placebo-controlled phase 1, phase 2 study, which they did initially for the safety and efficacy of allogenic bone marrow derived stem cell therapy for critical limb ischemia. So in this major study, when they did the multi-center trial and where they proved that in areas where there is a block, there is a new collaterals which are developing after injection. In areas where there is ischemia, there will be new collaterals which develop 6 months later. And our own Professor Rajkumar, who was the head of the Department of Vascular Surgery, so he was one of the principal investigators to show an improvement in the ankle pressure and the ABI, ankle brachial index, after injecting the stem cells in cases where there is a ischemia and patient is going in for a gangrene. So when they are going for a gangrene and when the blood pressure is low in the ankle, after injection, there is an increase in the ankle blood pressure as well as the ABPI index. So this is the publication showing that. And I am just showing one of our cases, who is a 42 years old male, chronic smoker with claudication and non-healing ulcer with distal pulses not felt. The vascular surgeon felt that since there is a the block is at the very distal end, there is no way to dilate this peripheral artery at the lowest level. And so this patient was referred to me for amputation. But I did not do an amputation. We injected his own stem cells. We took stem cells from his own body, from the bone marrow, and injected. And you can see that small collaterals have developed in the area where there has been no blood flow. So the main blood vessel will not open up. It is only the collaterals which develop after injections, which will improve the circulation to the foot, and then the foot can be saved from amputation. So here you can see that the ulcer area, when we saw the pulse oximetry, initially there was no flow. The pulse oximeter could not detect the flow, whereas after post-op, you can see that the pulse oximeter could detect the flow in 2015. This case was done in 2015. Till today, there is almost 9 years, this patient has not undergone amputation. And this is another case. This is diabetes, type 2 diabetes mellitus, and who is also a smoker, and whose angiogram also showed multiple level arterial blocks. Femoropopliteal bypass was already done 4 years ago, and the bypass got thrombosed after 4 years. So they were left with no choice. They tried prophundoplasty also, but that also failed. And ultimately, the vascular surgeon, the endovascular procedures, when they failed, he was suggested to go for below-knee amputation. But I did not do the amputation, so I took his own stem cells, autologous bone marrow, and then we could see here. You can see that this is the popliteal artery, which is normal on this side, is blocked here, and they have done a femoropopliteal bypass. So this bypass also got thrombosed. After 4 years, it got thrombosed, and then they tried prophundoplasty also. When that also failed, then he came with this reduced flow to the lower limb with again rest pain as well as a non-healing ulcer. And after injection, you can see the increase in the collateral circulations following this autologous bone marrow treatment. And many of the diabetic ulcers which have been treated in hundreds, the Department of Vascular Surgery in Madras Medical College and Stanley Medical College, they have done this, not only the trial using the bone marrow concentrate, they have also done with the bone marrow concentrate as well as cultured stem cells. So hundreds of patients were treated by Dr. Rajkumar and team using the Chief Minister's insurance scheme. And this stem cell therapy was covered in the insurance scheme through a special permission. And you could imagine that nowhere in the world except in India, this stem cell therapy is available to poor patients for free of cost. So these are some of the cases. 55 years old male with foot ulcer treated with BMAC, which completely went on to heal without any surgical procedure. One more recent advance using stem cells is the 3D printer for skin. So this is also an Indian government approved 3D printer, though this is from a Korean company. The Korean company in association with Alchem. So they formed a MOU with Alchem, and they did the clinical trial in India, and then they got the approval from the drug controller for doing bioprinting of skin for diabetic foot ulcer since 2022. So this is that product. Here you can see this is the 3D printer. So this 3D printer can be sterilized and it can be taken inside the operation theater. So, and it can be used for on-the-spot 3D printing using two bioinks. So here you can see you are seeing two cartridges. This is cartridge 1, this is cartridge 2. In cartridge 1, the bioink what we use is patient's own stem cells from fat. So when a patient has got a diabetic ulcer which is not healing, then we take the stem cells by doing liposuction from the patient's own abdominal wall, and then stem cells are separated from the fat. And the bioink 2 is what the company is already having ready-made, which is the fibrin glue. So when you take a photo of the ulcer, once you take the photo of the ulcer in a 3D camera, that photo is passed on to this 3D printer by Bluetooth. Once you send that photo of the ulcer to this machine, it will start printing within half an hour a patch of skin which contains the stem cells taken from patient's own fat, and then are the same size shape of the ulcer which can be placed over the ulcer, and then dressing can be done, and after 1 month you can see a good granulation tissue, and ultimately this ulcer went on to heal. So this is how that looks like. It looks like almost like an omelette. So you can see the consistency, which have rubbery and flexible consistency. You can see the same size and shape, which is just placed over the ulcer, and the dressing is done. Then again, other new therapies which are coming already in India, available in India, are from some of the stem cells and gene therapies for ophthalmology. As I told, ophthalmologists are the pioneers of stem cell therapies. You can see even in 1989, more than 30, 40 years, there was a concept and application of limbal stem cells. So the ophthalmologists found out that eye has got a very good source of stem cells. In the anterior chamber, you have got stem cells in the limbus. In the posterior chamber, you have got stem cells in the retina, and in the trabecular meshwork also, they have detected that stem cells are available. So limbal stem cell therapy is one of the work done by Dr. Virendra Sangwan of the L.V. Prasad Institute. And more than 35 years, these institutes, including the Aravind Eye Hospital, Shankar Nethralaya, and our own Egmore Hospital, Regional Eye Hospital, they are doing this limbal stem cell therapy. And they are also using autologous serum eye drops for dry eye disease. When patients have got dry eye, which is causing corneal ulcers, which are not healing for a long time, 2 months, 3 months, and then developing the scarring. So they have taken patients' own blood and prepared the autologous serum, and they have made eye drops from that, and they have given it to patients. And since 50 years, that is one of the treatment for dry eye disease, which is not amenable to any other form of the treatment. So eyes open on stem cells, it's an excellent name. So this is one of the as I told, the cornea has pioneered the seminal discovery of stem cell biology and regenerative medicine. And the children with cataracts regain sight after radical stem cell therapy for the cataract. When in adults, there is no need to go for any other treatment except other than this IOL. Today, IOL is a very successful treatment, and there is no need to look beyond IOL for the adult cataract. But it's not the case in children cataract, where when we do an implant for a child, when the eyes grow, the implanted lens does not grow, and so it has to be repeated as the child grows. So it's not a single stage procedure like adult. So they are exploring, and one of the procedures which they tried was stem cell therapy for the cataract in the young babies. And our own, as I told, Aravind Eye Hospital, they have moved beyond the cornea. All of us know that cornea, they have used stem cells for blindness, reverse the blindness. Similarly, for retina also, Aravind Eye Hospital has pioneered this platelet-rich plasma, which is taken from patient's own blood. You take 10 ml or 20 ml of the patient's own peripheral blood in the OT, and with a kit, you can prepare, do a centrifuge and prepare platelet-rich plasma. And that is used in cases of large macular holes where the patient loses vision. Previously, they were doing this limiting membrane flap, but they were getting only anatomical healing. But now, with the addition of autologous platelet-rich plasma, there is physiological improvement and a recovery of the vision also. And that is the finding from this study published from the Aravind Eye Hospital, the work of Dr. Naresh Babu and Dr. Kim Ramasamy and all the senior people who work in Aravind Eye Hospital. So, as I told, so this is the picture showing where they had shown the macular hole as completely healed. Not only healed anatomically, but they were able to get back the vision because the photoreceptors were also regenerated. Again, Narayana Nethralaya in Bangalore, they have come out with the first gene therapy trial. So this is not yet approved, but the trial is going on, gene therapy trial in India for eye diseases. It will be conducted in India and for some of the corneal dystrophies, congenital genetic diseases. So so all these latest technologies are being tried in India. You can see this is the last year, September, they have announced that they are ready for the gene therapy for corneal dystrophy. So, and they have identified 12 eye diseases. The lab plans to conduct trials, and sickle cell anemia and muscular dystrophy are also included in some of the diseases which are being tried for gene therapy in India. And this is one more Bangalore company. This is a private company, Pandorum Technologies, where they are, along with a partnership with Shroff Eye Hospital in Delhi, they have developed a bioengineered cornea, and they are seeking the DCGI nod for human trials. And here you can see this is a bioprinted. This has come from the lab where they have printed a cornea which can be used on the eyes to bring back vision in corneal blindness. So before I end this topic, so I just want to show the tissues, many tissues which we can regenerate. Previously, we were treating all diseases with only drugs. Mostly, we were treating symptomatic treatment in osteoarthritis and other painful conditions. We were giving painkillers, we were giving injections of steroids and all. So we were giving symptomatic treatment, or we were giving substitutive treatment. We were substituting if beta cells are not producing insulin, the insulin from outside. If dopamine is not being secreted by the strial neurons, then we give dopamine from outside. So we have not made the beta cell produce insulin again. We have not made the dopaminergic neurons to produce dopamine again. So that will be what we want to do and what patients expect us to do. When Banting discovered insulin 100 years ago, he said, the first sentence he said is, "This is not a treatment for diabetes. What I have discovered is only a substitution of insulin, and our research towards making the beta cell produce insulin again should go on." So these were the words by Banting when he discovered insulin. And even after 100 years, we are stuck with insulin. And now it is the time when we are moving towards the next stage where we can make the beta cells produce insulin again. But before that, hair regeneration is very, very possible nowadays. All dermatologists are today doing this hair regeneration. You can see that yeah. So here you can see the hair regeneration, skin regeneration in diabetic ulcers. In using PRP and stem cells, we have healed. Similarly, endometrial regeneration. Many gynecologists are doing in thin endometrium, Asherman syndrome. They are not only improving the thickness of the endometrium but also the vascularity. Angiogenesis, as I showed in that angiogram, whenever we injected stem cells, we get angiogenesis, new blood vessels. And unless we get new blood vessels, we cannot regenerate that organ. So similarly, this is for oligospermia and azoospermia. You can see in oligospermia, there is a increase in the count of the sperm. And it's not only the increase in the count, but also motility. Similarly, mucosal region. This is oral submucous fibrosis. My very close friend, Dr. Shankar Narayan, oral surgeon, dental surgeon. So he has treated submucous fibrosis. People take Panparak. When people take Panparak, they develop submucous fibrosis. And here you can see the histopathology where the collagen is totally destroyed. This is matted collagen. And after injection of stem cells into the mucosal area, you can see this wavy pattern. This is the wavy pattern is the normal collagen. So from abnormal collagen, you can see deposition of normal collagen, and that is how this fibrosis is reversed. And you can see small blood vessels, which is proof of angiogenesis. So mucosal regeneration, testicular regeneration, and then we have also regenerate. This is the vascular regeneration, blood vessel regeneration. Already we have shown this in critical ischemia, neural regeneration. So in cerebral palsy, where the child is not able to lift the head, now the child is able to lift the head. And again, this is melanocyte regeneration. See here, you can see patient who has got a vitiligo affecting the face in the outer canthus of the eye and beyond. So after we took his own melanocytes from his hair follicle. So our own AIMS Delhi Department of Dermatology, Dr. Somesh Gupta. So they have devised a technology where you can use patient's own hair. You can just take 30 or 40 hair follicles from the back of the head, and then because hair contains more melanin than the skin, you get more melanin from those 30-40 hair follicles, which you can extract and then inject into that area and get back. You can see almost the color of the skin is coming back. We have not injected into the upper eyelid because of the fear of edema. But even without injecting into the upper eyelid, you can see that gradually what the coloration, the melanin pigment is extending into the eyelid also. So with again, this is a case where post-operative you can see oral cancer. They have done a surgery. This is mandibulectomy they have done, and then for oral surgery they have given radiotherapy. The skin has become dry, it is cracked, and no sweat and sebaceous. Whereas after the injection of his own autologous, his own stem cells were injected, you can see that the skin regained its flexible nature and the secretion of sweat and the sebaceous glands. So now, when we talk about this regenerative medicine, it is mainly about platelet-rich plasma and stem cells. And platelet-rich plasma is when you take the patient's own blood and spin it. You do a centrifuge twice so that you remove all the RBC, WBC, and concentrate only the platelets within a few ml. So that is platelets contain all the essential growth factors. Platelet is like a drugstore. It is like a pharmacy. One platelet contains very many the growth factors like fibroblast growth factor, epidermal growth factor, vascular endothelial growth factor, insulin-like growth factor. This this platelet-derived growth factor. So all these growth factors are essential for healing, and that is what the dermatologists are using. All dermatologists today in India are well versed with the use of platelet-rich plasma (PRP) for hair regeneration and skin regeneration. And in orthopedics, all of us have taken up for every tissue whenever there was a pain or tear or injury in the bone, muscle, tendon, cartilage. We were injecting steroid everywhere. We were injecting steroid into the muscle, tendon, cartilage whenever there was injury, chronic injury. which was not healing by routine treatment. Now we are not injecting steroids. We are injecting patients who want platelet-rich plasma. We take his blood, separate the platelets, and then concentrate it, and then inject it into those areas and get regeneration. So it is possible to heal the chronic injured muscle, tendon, and all. So for sports physicians, plastic surgeons, for avoiding amputation, diabetologists and vascular surgeons are also using. As I told, gynecologists are already using endometrium. I showed a picture where they have used for endometrium, they have used PRP for regeneration of the endometrium, getting back the thickness, and also for ovarian regeneration. Ophthalmologists, I told already, for a long time they are using it for cornea, and recently they have started using for retina regeneration also. Pain physicians, anesthetists today are taking up a lot of degenerative musculoskeletal diseases with very chronic pain. So far, they were doing radiofrequency ablation, they were doing steroid injections, but now they are also in a big way. They have taken up injecting platelet-rich plasma or stem cells for regeneration of musculoskeletal pathologies. And as I told, dental surgeons, again, one of the few pioneers who have used PRP and stem cells for many of the conditions, chronic conditions of the mouth, like the oral submucous fibrosis, the dental cyst, the osteoradionecrosis, so following cancer. So these are some of the indications, some of the specialists who have already entered into the field of regenerative medicine. So
வெயிட் பண்ண சொல்லுங்க, ஒரு half an hour மீட்டிங் ஒன்று இருக்கு, வெபினார் முடிச்சுட்டு கூப்பிட்டுறேன்.
So when we come to the almost the end of the talk, so when people used to want to know about the cost of the product, so I thought before the questions are asked, just I put a slide mentioning what is the MRP of these products which are available in India. So for CLI and PAD, when there is a non-healing ulcer, depending upon the patient's weight, if we want to buy 150 million cells or 200 million for each kg body weight, we have to use 2 million cells. So, and this is the cost. And for osteoarthritis, for one knee, that vial contains, this vial contains 25 million stem cells, and the cost of that product is 1.25 lakhs. And some of these growth factors, VC growth, this is for skin and hair. So this is for 3,000 rupees. So this is, before ending, I just wanted to also show the financial status of these products. So I really thank the organizers for giving me.
Thank you, Ravi sir. May I introduce Rajkumar sir, Professor Rajkumar, Senior Consultant Vascular Surgeon in Chennai Apollo Hospital. Sir did MBBS from Stanley Medical College, MS from MBBS from MMC, Madras Medical College, Stanley. He did a DNB from the DNB from Delhi and MCH Vascular Surgery from MMC 1999. Sir is the Professor Emeritus of the Tamil Nadu Dr. MGR Medical University, Founder Director and Institute of Vascular Surgery at Madras Medical College. Started the Department of Vascular Surgery at Stanley Medical College in the year of 2006. Started MCH Vascular Surgery at Stanley Medical College in 2007. Sir is a stem cell research in NOCLI with the Stemcell technical medical expert in Lifestyle India as a board member, and published many papers in national and international index journals. Awarded a Best Doctor Award by the Dr. MGR Medical University, Best Researcher Award by the Stemcell. Rajkumar sir, very proud of you as a moderator today. Please take over, sir. Thank you, sir.
Good evening. Thank you for this wonderful and kind introduction. Stem cells, as we know, is multipotent and polypotent and pluripotent. Stem cells are found in abundant quantity in children and in fetus. See, they are the ones which form the ectoderm, endoderm, and the mesoderm, and helps in repair and growth of organs. As we grow old, the stem cell comes down in the human body, and it's particularly found in rich deposits in the bone marrow. The sources can be embryonic stem cells, or bone marrow stem cells, limbal stem cells, and so on. And in, of course, in our own blood. Stem cells are wonderful in the sense we are not going against nature, but we're going with nature. It acts at a very molecular level and produces a lot of growth factors. And stem cells propagate by neovasculogenesis. So this vasculogenesis helps in repair of all tissues, whether it's skin, cartilage, bone, blood vessels. So since they propagate by vasculogenesis, it's very useful in vascular diseases where conventional therapy is not possible, as in Buerger's disease or in critical limb ischemia in diabetes or vasculopathies, or even in venous ulcers. So stem cells can be obtained. Now it's in the market, but it's at a very high price. As Dr. Ravi puts it, the cheapest stem cells would be autologous stem cells, which can be produced by BMAC technology, bone marrow technology. So both are equally efficient. Stem cells, the advantage of stem cells is it can be injected under spinal anesthesia or local anesthesia, as the indications may be. And stem cells will home into the area where it is needed. Stem cells home into an area, a target area where there is hypoxia, and stem cells specialize into cells which are deficient in that area of targeted areas. So stem cells are wonderful. It takes about 2 weeks for the stem cells to stabilize. After it stabilizes, and the maximum result can be seen in 6 weeks if it's ulcer healing or if it's going to be rest pain. I was one of the principal investigators right from the time they started this program protocol, from phase 1, phase 2, phase 3, and of course post-marketing. So we said this can be used only when there is no option to conventional therapy like angioplasty or stenting or bypass surgery. And there's no option in patients with subcritical limb ischemia, but 40% of the limbs are lost due to amputation, which can be otherwise saved by using stem cells. So stem cells help in limb conservation and limb preservation, and stem cells can be repeated after 6 months or 3 months if need be. And stem cells are only place where the stem cells don't give good results are in renal failure and in congestive cardiac failure, where there is low flow state. Otherwise, stem cells, there's no contraindication, except for the cost, which is very high. I think we should try to ask the companies to reduce the rate so that more people will benefit by the use of stem cells. And the future of medicine is going to be molecular medicine, as all of you know. And AI is going to have AI and science and technology is going to have a vast impact and influence on our own medical science. So it's high time that all of us get acquainted with AI, the benefits and the demerits of AI, and we should know where to draw a line. So stem cells will be very useful in the sense it does not require any knife to cut up a patient. There is no blood loss in stem cells. And in patients with rest pain, I have seen in my own trial and in my own experience that within 3 days, rest pain disappears. And ulcer healing starts from the 2nd week, and within 6 weeks, the ulcer heals. They produce collaterals, which can be imaged through a MRI. And these collaterals will substitute for the axial anatomical blood vessels. So they are very useful. So even today, we don't have a technology to image the collaterals except for MRI, but to quantify the collaterals through medical treatment, there is no particular technology, but collaterals do an excellent job. We know the similar collaterals are available in the coronaries. That's why in medical treatment, so many of them will still survive without stenting or a bypass. So stem cells are wonderful. They are highly plastic and malleable. It can be used in so many conditions like retinopathy, corneal ulcers. It can be used in osteoarthritis. It can be used in Perthes disease. It can be used in infertility to improve the quantity of ovaries or the sperms. Quantity, not only quantity, quality also. So stem cells are wonderful, and I think it has a wonderful future. People, more and more of our practitioners and doctors should take up stem cells as part of their practice. The patients will benefit, and of course, the individuals who practice stem cells will be rewarded. If you have any other doubts, you can ask me.
Sir, that is why our AMS team has considered taking up regenerative medicine as
Yeah.
a certificate course, and they have asked us to formulate a curriculum so that people who are really interested, who want to know about and get trained in stem cell therapy, they can also get the benefit.
I think we should prepare a syllabus
Yes.
and submit. Yeah.
Sure, sure, sir. Sure, sir.
It will be very useful.
Wonderful.
It will be very
Exhaustive,
useful.
wonderful presentation.
And
Need
this
us aware.
the awareness is not much. When I initially used to present papers in Vascular Society of India, there used to be a lot of objections and voices from the other end. But when I went to the SVS, I used to regularly go to the SVS conference, Society of Vascular Surgery conference in the United States, which is the apex body for the vascular surgeons and vascular specialists. There they are using stem cells. In UK, they are using stem cells. In Europe, they are using stem cells. So lack of knowledge can be one of the reasons for the resistance.
Dr. Raj, to my classmate, 74 batch alumni MMC.
Wow,
Very
super.
happy to see that guy.
Yeah.
Very simple, humble, and easily approachable person. Only question to Raj.
Yeah.
What is the impact of stem cell therapy in COVID-treated patient? Any impact or no impact?
No, COVID-treated patients would be very useful if you need it. Because
male
there
and
is
female, is a difference. Because somebody say impact is a difference in outcome is better in male or female. So what is your opinion?
No. So as long as the quantity, there's a cell count. See, when we extract the autologous stem cells, we do a cell counting and cell quality check. That will tell you about the quality and tells you now, of course, after the allogenic stem cells have come, they are already standardized. It is produced by the 3D biological generators. It will be very useful because wherever there's an immune deficiency, stem cells will definitely play a good role. And another thing with all these post-COVID people, all of the COVID, primarily it affects the endothelium. It affects the vascularity. That's why you see post-COVID, a lot of people will have peripheral arterial disease or carotid arterial disease or even coronary arterial disease, which is not highlighted. People were able to highlight the pulmonary part of the coronary artery. Basically, it affected the endothelial function and it impaired the endothelial function, promoting
Avascular
thrombosis.
necrosis also.
EDRF. See, that's the reason in COVID, if you have treated the patient with a low molecular heparin, with the anti-COVID, they had a better prognosis and they never went into development of pulmonary fibrosis and other things.
Okay. So HLA typing is a must.
Component of preserved.
HLA typing is a must in stem cell therapy?
Not necessary. If you have blood group is important. Okay. If it's going to be autologous, there's nothing is required. It's as good as a blood transfusion.
Fine. So thank you, Raj.
And there is no reaction. So far, I have not had a single case of reaction with stem cell therapy. All are doing well. All my patients are doing well. And I have treated 85-year-old person and 90-year-old persons. Yeah.
Thank you, Raj.
Please, Jalil, sir, please. Ask. Jalil, sir, you can ask.
Sir, I am Dr. Jalil.
Yes, sir.
Powai AMS secretary. I am a neonatologist and a senior pediatrician, sir. What an amazing lecture today, sir, by Dr. VRR. It's an amazing lecture. Very latest messages. As a pediatrician, I can understand such a wonderful, such a meaningful indication of this. And I know the regenerative medicine is growing up. And you have said the combination of AA and the regenerative medicine is going to boom in our country. And I wish VRR sir to have many more presentations like that. And as a neonatologist, can we use the card? Usually during the delivery, we used to collect the stem cells and it lie ideally without being, it was told us only it is meant for like for example, blood diseases like that, thalassemia like that. If those samples can be used for any other disease, what you have mentioned for the same passion, the collected umbilical cells.
Umbilicals, the Lifestyle International in Chennai, they are using this cord blood to produce various biological dressings. And also they are going into many products. The problem is getting permission from the DCGI, Drug Control Journal of India. They have a stem cell separate stem cell approving board there. There are 21 people who sit for the stem cell approval, and most of them are not, I don't know. I don't want to say they are not very helpful. In one of the meetings, one of the person said, "Does the stem cell work?" And he himself is working in a stem cell lab. I said, "If the stem cell doesn't work, how are you running a lab?" I asked. Stem cells work. The problem is you have to understand how it works. You have to go into the basic biology of a stem cell or basic biology of a cell first, then understand it. It works because anything living will work. And it's up to us to take it up in a way and do some publication of papers or go to the National Medical Council and personally meet them and tell them that before we lose out with the other countries that we should go ahead. Only then they will encourage us. As you said, it's got a wonderful role, sir. See, before, as somebody asked, Plecentrix was used for wound healing. It's a crude form of stem cell. Even now, there is aloe vera gel with a aloe vera with alloyant is
algae.
Is used for wound healing. So definitely it will help. Those days, placental membranes was used as a covering for burns. The wound was healing without a scar.
So since you have mentioned this stem cell therapy can be used for a devastating or critical burn injury, sir.
Very true, sir. Very true.
It is
can be used.
It's a bloom. Actually, I was amazed by listening to this lecture, being a pediatrician and neonatologist. But now the growing medicine, and I should appreciate the AMS and our chairman Ramesh Babu to taken this latest messages to the practicing physician. Thank you, sir. Dr. VRR, wonderful, sir. We would like you to present this in our forum also in future.
Thank you.
What you are mail, and it will be very useful, sir. Thank you so much.
Thank you.
Sir, there is a question, sir. Is there any treatment for osteophytes of the multiple bones in 70 years old male patient?
Multiple joint, as I think he is mentioning about spine. So osteophytes at multiple places in the spine is one of the conditions like ankylosing spondylitis, which will cause a terrible pain and stiffness. If it is pertaining to only one joint, suppose it is only hip joint, he has got multiple osteophytes, or knee joint, one knee joint where there are multiple osteophytes, then this therapy will definitely help in relieving the pain as well as regenerating the cartilage. But in spine where the multiple discs are involved and multiple vertebrae are involved, then it is not possible to cure with a single dose. Probably they will need multiple doses.
One more question, sir. Is there any link between stem cell therapy and older Plecentrix treatment?
Yes, sir. Plecentrix is actually only the scaffold. They only preserve that membrane. Structure will be there. There will be no live cells. It will not contain any live cells, so there will be no stem cells. It is only the structure which is retained. Structure is also important, like a scaffold, but it has got a limited use only. So small wounds, they used to preserve the number. We have seen நம்ம ஊர்ல தாயத்துல கட்டி வச்சிருப்பாங்க இது பிளசண்டாவை. So அதை பொடி பண்ணி they used to apply for non-healing ulcers. So it helps in small wounds, but in major wounds and major situations, the placenta alone cannot help because it does not contain live stem cells.
One more question, sir. Is it useful in the treatment of a bronchopleural fistula, post-infective or post-malignancy bronchopleural fistula? Is there any role of stem cell therapy in a bronchopleural fistula?
Yes, sir. Actually, the clinical trials are ongoing. So after phase 2, phase 3, they have found use in the phase 1 trial. Animal trial was very successful. Then they have gone in for phase 1 trial, and now they are into phase 2 trial. And once we get the results of phase 2 and phase 3, we will definitely know where to give, how much to give, which stage we should give. So because it is similar to what I am saying, no, there's perianal fistula in Crohn's disease, multiple non-healing perianal fistula in Crohn's. So that already it is approved in Japan and Korea, and in India phase 2 is done. So this is also all these fistulas, there is a possibility. So we have to find out the dose.
Thank you very much, Ravi sir and Rajkumar sir, for the wonderful exhaustive presentation. Need of the other topic. This is very, very important. Futuristic medicine is a regenerative medicine. There is no doubt. With the AI involvement, so this will be a very, very growing field there. Needs everyone attention. We have to have the frequent lecture like this. This is a very important. Crystal clarity. I thank you. I enjoyed a lot of things I have learned from you, sir. Ravi sir, thank you very much. And Rajkumar sir, wonderful. You are the pioneer in this field of regenerative medicine. So we are all lucky enough to listen to your lecture. So thank you very much. Wonderful opportunity. So very nice, enjoyed, sir. With a lot of we have a frequent meeting in Chennai and other areas to update. A lot of lack of awareness in this stem cell therapy and all.
Sir, anyhow, we are applying for the approval of the course with the IMA AMS, sir. Once they approve it, we will start the course. Periodically, we will be having the courses, sir. So that your aim of getting more people trained and more propagating, we will do it, sir. That is the main aim of doing it. As you are telling in the first slide itself, for the MBBS person has to know. So everyone will be taught. So basically,
just one point.
Yes,
just
sir.
one point. This propagation of stem cells, when it divides into a specified and a non-specific cell. So each cell will divide into a specific targeted cell and one non-specific. So the propagation is continuous, perpetual. So it doesn't stop. That's the wonder of the stem cell. It divides into a non-specific and a specific cell. And this non-specific cell again will divide into a specific and a non-specific cell. So it's a continuous propagation, asymmetrical propagation it is called. Asymmetrical, just I failed to tell this. So this is the backbone of stem cell therapy. Thank you.
Thank you.
Thank you, Ravi. Wonderful. Yeah.
Lot of thanks message to Ravi sir
and
Rajkumar sir. Excellent. You can present your topic on hepatitis advancement, management and prevention and all.
About viral hepatitis, but specifically, I just want to concentrate on both viral hepatitis B and C because these are the both dreadful viruses we come across, and that is causing a lot of cirrhosis as well as risk of hepatocellular carcinoma. So the goal and endpoints of therapy are like the goal of therapy is to cure the hepatitis C, preventing the development of cirrhosis, and measure the level of HCV RNA mainly when they like a PCR based assay test we do, and the LDL should be, that is lower limit of detection should be less than 15 ml. 15 international units per ml. So what is the goal is the absence of a virus at end of 12 weeks of therapy after the advent of this directly acting antiviral therapies. Earlier we had only PEG interferon and ribavirin therapies which did not give us the definitive endpoints. So nowadays after the advent of directly acting antivirals, the results are very good, and patients develop this complete negativity in hepatitis C at the end of 12 weeks when compared to what we say the sustained virological response at 12 weeks is completely negative. They touch the negative levels. So what are the pre-treatment tests we do? A detailed history and physical examination, history of any alcohol consumption or drug abuse, cardiac, pulmonary, psychiatric evaluation should be done if indicated. And baseline tests include a complete hemogram, LFT, PTINR, renal functions, and thyroid functions. And very important, this IL-28 polymorphism. This has been checked nowadays. That gives us the idea about the spontaneous clearance of hepatitis C infection. And the response to treatment with the PEG interferon-based regimens also, this IL-28 polymorphism has been checked. And coming to the detection of liver fibrosis and cirrhosis, biopsy remains the gold standard, but generally in clinical practice, we decide cirrhosis by the combination of clinical, biochemical, sonographic, and endoscopic criteria. So coming to the guidelines for treatment for hepatitis C. When a patient is confirmed with a hepatitis C infection, we do the basic test, HCV RNA levels, some fibroelastography and some fibrosis scores based on the baseline test. And with these, if the patient do not have cirrhosis, then treat with the newer drug, that is Sofosbuvir, 12 weeks. And then again perform the HCV RNA after 12 weeks. So again, if it is become negative, then just these patients are SVR 12, that is the patients are remain negative, that is at the end of 12 weeks. So if the patient has features of cirrhosis, if the patients have cirrhosis which is compensated child A, then treatment with Sofosbuvir with Velpatasvir combination. Both are directly acting antivirals. They target certain receptors in the structure, that is NS5A, 5B polymerase in the structure of the HCV. And these two drugs are given for 12 weeks duration. And again, the HCV RNA is performed at the end of 12 weeks. If still the HCV RNA is detected, then there should be some resistance in the drug, and patient has to be referred to higher centers. So with this picture clearly shows the progressively improving treatment options of hepatitis C, with initially with standard interferons, then ribavirin, then pegylated interferons. Now the directly acting antivirals has taken over. This is a structure with targets for DAA, that is directly acting antivirals against hepatitis C. So the most of the drugs available in India are mainly the NS3 protease inhibitors, that is Simviprevir, Glicaprevir, and Grasoprevir. And we use commonly the drugs we use are NS5B nucleoside inhibitor and NS5B non-nucleoside inhibitor. So among the nucleoside inhibitors, we have Sofosbuvir, and non-nucleoside we have Dasabuvir. And the other group, that is NS5A replication complex inhibitors, are Decletasvir and Ledipasvir. These are the common drugs available for our use in our country. So the drug available to start with, a pegylated interferon 2A and 2B. 2A is used at a dose of 180 milligram per week, and 2B, it is used on kilogram based, that is weight based, that is 1.5 mg per kilogram per week. But we have to keep in mind the side effects like anemia, pancytopenia, and other side effects are like flu-like symptoms, fatigue, sleep disorder, autoimmune reactions, visual disturbances, interstitial lung disease, and thyroid function abnormalities. And also very important, the PEG interferon alpha should be used with caution in patients with advanced cirrhosis, because hepatic decompensation may occur. Next comes the ribavirin. Ribavirin is also available. The recommended dosage is mainly if the weight is less than 75 kilos and weight more than 75 kilos. If weight less than 75, it is 1000 milligram per day, and for more than 1200 milligram per day. And side effects for ribavirin is mainly anemia. So ribavirin should be adjusted by 200 milligram if every hemoglobin drops below 10 grams. And it should be stopped abruptly if the hemoglobin level falls below 8.5. Also, it has teratogenicity, so 6 months gap should be kept for the first class that it inhibits viral RNA-dependent RNA polymerase encoded by NS5B. A very important point to remember is it is not recommended in patients with severe renal impairment when the eGFR is less than 30 ml per minute. And common side effects includes fatigue, headache, nausea, insomnia, and anemia. So, and other thing to be kept in mind, it should never be added with the patients who are taking amiodarone, because due to the serious risk of symptomatic bradycardia. Ledipasvir is the next group of drug, which is inhibits NS5A, mainly used for genotype 1 and 4. It is not effective for genotype 2 and 3. If the patient is using any acid suppressing medications, Ledipasvir should be administered simultaneously with H2RA or a PP, and at least 4 hours after antacid, since its solubility decreases as the gas pH increases. And Decletasvir is used again genotype 1 and 3. The dosage is 60 milligram. And Velpatasvir is 100 milligram. It is used in patients with severe hepatic impairment without any alteration of the dosage. The major adverse events reported are again headache, fatigue, and nausea. So this is the national guidelines of diagnosis and management of viral hepatitis. Here, patients without cirrhosis who are uncomplicated, we use a 2-drug combination, that is Sofosbuvir with Daclofenacin for 12 weeks, and the treatment is complete. Then patients with cirrhosis with child A, that is child A score, then Sofosbuvir with Velpatasvir, the same 12 weeks. When patients goes on into child B and C, then the dosage duration has to be increased or ribavirin has to be added. So Sofosbuvir, Velpatasvir with ribavirin 600 to 1200 milligram. In ribavirin intolerant patients, the dosage of this one is extended to Sofosbuvir, Velpatasvir is extended to 24 weeks. So we have also we have to keep in mind about the resistance to drugs, various quasi-species resistance and other various resistance testings are available. But in India, routinely we don't have any such testings. So it's not routinely available and feasible also. There is a drug for all these resistance. When the patient develops DA resistance, this oxaliprevir is most commonly used, but it is not available for us. So again, there is a treatment failure things that is PEG interferon failure to Sofosbuvir, and even all the NS5A inhibitors. So this one, so in that case, we have to defer the treatment completely. So all the antivirals has to be deferred, and this patients has to be started on this resistance testing is not available. So anyway, these patients has to be put on the routine drugs, but little extended duration, like along with a combination of ribavirin. So when special situations like HCV and HIV, when a patient presents with HCV, who has been co-infected with HIV, so mainly occurs in common in the injection drug abuses. So this HIV infection will significantly alter the natural history of HCV, leading to rapid worsening, risk of decompensations, and it hastens the fibrosis progression also very rapidly. So generally for a HCV infected patient, there is a spontaneous clearance in 5 to 10%, 15 to 30% in a HIV non-infected patients, whereas in HIV co-infected patients, the spontaneous clearance is only 5 to 10%. So the indication for treating HCV and HIV is similar in those infected with either alone. So the indications will be like Sofosbuvir 400 milligram. Sofosbuvir 400 milligram and Velpatasvir will be 100 milligram. That is for again 12 weeks, and these patients has to be checked for progression of the cirrhosis. And other combinations are Glicrapravir and Pvt.Ltd. These are the other options for HIV co-infected patients. With cirrhosis, it is 12 weeks, and without cirrhosis, it is 8 weeks. So according to AASLD and EASL recommendation, that is European Society and American Society, when a patient presents with this HIV co-infection, there is also another entity called HBV and HCV. So far, we have seen about the HIV and HCV. Now it is HBV and CV. So both mainly for drug abusers and those with high-risk behaviors, we could see these co-infections commonly. When the patient comes, the HCV patient comes with a surface antigen positivity, then they are at risk of flare during the hepatitis C treatment. So during the hepatitis C treatment, these patients has to be monitored for the hepatitis B DNA also, and LFT, that is SGPT levels every 2 months, and also 3 months post-treatment. So, but European Society recommends a concomitant use of nucleoside analogs until 12 weeks post-DAA therapy. Next group includes surface antigen negative, anti-HBC positive, that is core antibody positive. So they are at low risk of flares during the antiviral therapy. So monitoring SGPT at baseline and during follow-up and end of treatment is sufficient. So if the SGPT is elevated and does not normalize during the treatment for HCV or post-treatment, then monitor the DNA and surface antigen. And also check for the hepatitis B reactivation if there is an elevated SGPT. So in cirrhotic patients, the nucleoside analogs are started before or together with HCV treatment, regardless of their viral load. But when patient initially presents with cirrhosis, you can treat both simultaneously. That is what the flow chart says. The HCV RNA positive, HBV DNA negative patients with only surface antigen positive, but they come with a cirrhosis. Then start both treatment for hepatitis B and C. When they come without cirrhosis, then only HCV treatment and monitor for HBV reactivation. But initially, when the patient comes with surface antigen negative, but only occult HBV positive, then DAA treatment and monitoring for reactivation is sufficient. So in the pre-transplant group, while the patient is getting ready for a transplant, when a hepatitis C patient, infected patient is getting for a transplant. So what this treatment for HCV in patient listed for transplant, they had been shown to prevent the decrease in HCV recurrence after transplant. So these patients, when they are started with HCV therapy, they have a good income because the good outcome they have. This HCV recurrence after transplant has been decreased. Even in the pre-DA eras, now the advent of DAA has greatly simplified. So these HCV patients who are listed for transplant also can be treated for the better outcome post-transplant and to prevent the recurrence. And a study by Curry et al. Demonstrated that Sofosbuvir and ribavirin given before liver transplant, they resulted in a good post-transplant virological response and also prevented the recurrence of HCV. So management of patients after liver transplantation. So post-transplantation, this graft reinfection is very common, and they lead to graft fibrosis, cirrhosis, and even decompensation. So successful therapy has been shown to have a positive impact on both graft and the patient survival. So patients who have completed the liver transplantation, they develop a HCV infection. So the natural course of HCV infection is accelerated in liver transplant recipients. So 15 to 30% will progress to cirrhosis within 5 years, and 2 to 9% may have a complication called fibrosing cholestatic hepatitis. So the optimal timing for HCV treatment for them is soon after the liver transplant, before any significant liver disease develops, usually 3 months after liver transplant, like post-op issues getting resolved, renal function comes to normal, and the immunosuppression is stabilized, and there is no ongoing any acute rejection. So there are various drug interactions needs to be considered. One is the protease inhibitors containing DAAs and calcineurin inhibitors and mTOR. These are the different targets against which the drugs have been introduced. Okay, and pregnancy. This is a very important thing. The risk to the baby, that is chronic HCV, is more in HIV/HCV co-infections. So the risk of teratogenicity using ribavirin, so defer conception at least by 6 months if ribavirin is prescribed as a treatment for HCV. And treatment during pregnancy is not recommended. And avoid any invasive procedures during delivery, like forceps delivery, fecal scalp monitoring, and defer the mother's treatment till delivery. Continue usual breastfeeding unless there is a cracked nipple, and test the baby at 18 months because as maternal antibodies will be present up to 18 months. If the patient presents with decompensated liver disease, if the MELD score is 18 to 20, and these patients are transplanted first and then treated unless there is any waiting time is more than 3 months. If the MELD score is less than 18 to 20, then the patients can be treated prior to the liver transplantation. So very important to be considered is do not use protease inhibitors in the treatment regimen, and increase the duration to 24 weeks if they are ribavirin intolerant or if they develop any anemia, severe anemia, and which forces to stop ribavirin. And the best combination is Sofosbuvir, ribavirin with velpatasvir for 12 weeks. Treat with caution because patient might worsen during the treatment, and look for the other toxicities like ribavirin anemia and directly acting antivirals for liver toxicity. So monitoring worsening of the liver status in the form of ascites, jaundice, any varices, renal function test, anemia, and sustained virological response. And also in between, we have to check for the HCC, that is hepatocellular carcinoma surveillance also. In the CKD subgroup, HCV itself can cause a CKD, chronic kidney disease, as a extrahepatic complication of hepatitis C. Furthermore, there is an increased frequency of proteinuria, and also the progression of CKD will be more faster, and higher all-cause mortality or dialysis in HCV infected patients. So timely treatment of HCV infection is important to optimize the outcomes in the CKD groups. When a patient comes with acute HCV, after the initial diagnosis of HCV with viremia and the RNA quantification, this HCV treatment should be initiated without awaiting any spontaneous resolution. Counseling is recommended for patients with acute HCV infection, mainly to avoid hepatotoxic insults, including drugs, acetaminophen, alcohol consumption, and to reduce the risk of HCV transmission to others. So referral to addiction medicine specialist is recommended for patients with acute HCV infection, which is related to substance abuse. Due to high efficacy and safety, the same regimen that is recommended for chronic infection is recommended for the acute infection also. Children who are born to women infected with HCV should be tested for infection after 18 months. And symptoms of chronic HCV infection in the pediatric population are usually absent. Cirrhosis and HCV are rare, but however, liver disease can progress very fast during the early life. According to European Society, for children, the fixed dose combination of Sofosbuvir and Velpatasvir same is applied for 12 weeks. And as per the weight-based regimen, for those weighing more than 17 kilos, the Sofosbuvir 200, half the dose as compared to adults. And those weighing less than 17 kilos, still more lesser, Sofosbuvir 150 and Velpatasvir 37.5. So follow-up will be the ACV RNA levels to be checked. That is sustained virological response is strongly associated with decreased liver-related mortality, decreased hepatocellular carcinoma, and decreased rate of decompensation. So various studies have done, included 30,000 patients who showed a sustained virological response, and it also significantly decreased all the complications as mentioned earlier. And long-term follow-up studies for patients treated with DAS estimate the rate of late relapse, that is not reinfection, at least 0.5% after 1 year of follow-up. So chronic hepatitis patients should be counseled about the how to maintain the liver health by minimizing our abstinence from alcohol, and also the other risk factors for metabolic syndrome has to be kept under control, which could lead to further progression of liver disease from NASH, that is non-alcoholic steatohepatitis. And patients with fibrosis stage 3 and 4 needs regular follow-up and HCC surveillance by periodic alpha-fetoprotein monitoring as well as imaging. That is a triple phase liver specific imaging, mainly to rule out any conversion of cirrhosis to any malignant nodules. It is generally recommended to recheck the HCV RNA once more at the year of 1 year post treatment also. So why I gave more importance to hepatitis C is nowadays we have all very the boon to newer medicine like antiviral drugs, directly acting antiviral drugs. With just 12 weeks of therapy, patients become totally negative for hepatitis C, and all the very dreadful complications of chronic hepatitis C have been checked with this wonderful drugs. And a few slides about hepatitis B management also. Again, the same endpoints will be the HBV DNA, that is long-term. HBV DNA levels should come down, and then EAG loss, that is envelope antigen. Envelope antigen is one antigen which denotes the viral replication and infectivity to others. So this induction of HBeAg loss with or without anti-HBe seroconversion, that shows the partial immune control of chronic HBV infection. And biochemical response is defined as ALT normalization, particularly SGPT. SGPT should be normalization should be considered as an additional endpoint. It is achieved in most patients with long-term suppression of hepatitis B replication. And finally, HBsAg loss, that is surface antigen loss, that is with or without antibody formation. Anti-HBs seroconversion is an optimal endpoint which shows the profound suppression, that is the profound suppression of HBV replication and viral protein expression. So the recommendations of treatment, the main advantage is to of these tests are mainly to allow safe discontinuation of the drugs. So the patients with chronic HBV infections have been completely eradicated due to cannot be eradicated because there is a persistence of CCC DNA, that is covalently closed circular DNA, which is mainly in the nuclear core DNA, not eradicated integrated in HBV DNA. So HCC may still develop even after spontaneous HBsAg loss. So so many drugs are available for hepatitis. Still this small quantity of completely eradicated. So there is always a risk of HCC even after spontaneous HB surface antigen loss. So the risk is lower if HbA1c loss is achieved at the younger age. And early treatment, early approach to a physician or a hepatologist, and early treatment will reduce the conversion of cirrhosis and other cirrhosis related complications. So the risk is lower if HbA1c loss is achieved at an young age, or in the absence of any significant fibrosis. So what are the recommendations for treatment? So all patients with hepatitis B envelope antigen positive who are highly infective or negative chronic hepatitis B, that is defined by DNA of more than 2000. So 2-3 tests we have to comes with the hepatitis. One is a basic liver function test. We are going to check for the SGPT, how many levels it is elevated, how many times it is elevated, the upper limit of normal, and how much is the hepatitis B DNA viral load, and hepatitis B envelope antigen that shows a high replication and infectivity. When antibody to HBE is developed, it shows a protection. And then comes the occult B, when there is a core antibody positive. That is even a very microscopic amount of infection also is detected by the core HBC, that is IgM anti-HB small c, that is core antibody. So based on the 2-3 lab numbers as well as ultrasound, and if there is a facility of fibroscan, that is elastography studies are available, that also can be. So patients with compensated or decompensated cirrhosis needs treatment with any detectable HBV DNA. When a patient comes with a cirrhosis, then whatever the level of, irrespective of the level of HBV DNA and regardless of the SGPT, we have to treat them. And patients with hepatitis B DNA more than 20,000 and SGPT more than 2 times the upper limit of normal, then start treatment immediately, regardless of the degree of fibrosis. Patients with envelope antigen positive and with chronic HBV infection who are defined as a persistently normal ALT and high DNA level, they may be treated if they are older than 30 years, regardless of the severity of liver histology. But nowadays, we are not doing any liver histology as a routine workup. So no biopsy is routinely recommended. So patients with HBeAg, envelope antigen positive or negative chronic HBV with a family history of a hepatocellular carcinoma or a cirrhosis or any extrahepatic manifestation, they have to be treated even if any other treatment indications are not fulfilled. So with chronic HBV infection, either with normal SGPT or stiffness more than 9 kilopascals or elevated ALT, but below 5 times the upper limit of normal, and liver stiffness of more than 12 kilopascals at elastography, that is fibroscan test, they have to be considered to have severe fibrosis and cirrhosis. So how are we monitoring the patients currently who are not treated? So as per recommendations, guidelines, patients with envelope antigen positive chronic hepatitis B who are younger than 30 years and who do not fulfill any of the above treatment indications, whatever I have discussed earlier, they should be followed at least 3 to 6 months. So 3 to 6 monthly, they have to come every 3 months of LFT, HBV DNA, viral. The that is envelope HBV with the DNA less than 2000 and who do not fulfill the above criteria, then they have to be monitored every 6 months with an LFT with viral load and at least 5 for 3 years or normal ultrasound, that's the liver fibrosis. And patients with the HBeAg negative chronic infections with a DNA of more than 2000 and who do not fulfill the above indications, again ALT is checked every 3 months, first year, and then 6 months, then DNA assessment and liver fibrosis every year for next 3 years because we are not starting them on any treatment. So this table briefs us the usage of different drugs. So earlier PEG interferon alpha 2A, which was used 180 microgram weekly for more than a year, and it was given as more than 1 year dosage, 6 million international units per meter square, 3 times weekly. But side effects to be considered are flu-like symptoms, fatigue, pancytopenia, autoimmune disorders, anorexia, weight loss. And so monitoring of a complete blood count, thyroid, Other autoimmune, ischemic, neuropsychiatric, and infectious complications are warranted. Then comes the entecavir, which is the most safer drug. It is given as a dosage of 0.5 milligram daily. For more than 2 years dose, weight-based that is 10 to 30 kilos, and those who are above 30 kilos. So 0.5 milligram daily. Again, the complications or the side effects we have to think in mind, have in mind is lactic acidosis in decompensated cirrhosis patients. So the lactic acid levels are always a concern, so we have to keep checking it and test for HIV before treatment initiation also. Coming to tenofovir TDF, that is depo-voxyl fumarate. Now this tenofovir alafenamide has taken over because it has extra advantages and less side effects compared to the plain tenofovir which was used earlier. So this tenofovir alafenamide 25 milligram daily is the now recommended dosage. So peg interferon is a subcutaneous injection. It is given for 48 weeks. So the long-term safety concerns are it has a lot of adverse effects and psychiatric, neurological, endocrinological side effects. So it is contraindicated in decompensated disease as well. The effect of HbEAg loss is only moderate. So effect of HbSAg loss is variable, and the relapse also is very after cessation. It is low for those who have sustained response for at least 1 year post therapy. So as per the guidelines, when the chronic HBV patient comes to you, the HbSA first check for the surface antigen, envelope antigen, and occult B. If the surface antigen is positive, the patient is having chronic HBV infection without any signs of hepatitis, like liver function is totally normal. Then again monitor the LFTs, HbSAg and HbE antigen and HBV DNA and fibrosis assessment. Consider if there is a risk of hepatocellular carcinoma is high, risk of HBV reactivation and extrahepatic manifestations, and risk of transmission to others is high, then go for antiviral treatment. If nothing is there, then just keep monitoring the patient. Again, in chronic hepatitis B, with or without cirrhosis, start treatment, antiviral therapy. And if the surface antigen is negative and occult B is positive, that is anti-HBC is positive, then no specialist follow-up, but inform the patient and general practitioners about the potential risk of HBV reactivation. In case of immunosuppression, start oral antiviral prophylaxis, or we have to monitor. Then the virological response with nucleoside therapy. So this any therapy virological response during this nucleoside analog therapy is defined as it should become undetectable by a sensitive PCR with a limit of detection of 10 units per ml. And there are different definitions here. That is primary non-responders and those with partial virological response. So primary non-responders are defined by less than 1 log reduction of serum HBV DNA after 3 months of therapy. And partial virological response is defined as a decrease in HBV DNA of more than 1 log per ml, but detectable HBV DNA after at least 12 months of therapy in compliant patients. Then there is a term called virological breakthrough. So virological breakthrough, when there is a confirmed increase in level of more than 1 log per ml compared to the lowest value of HBV DNA, they may precede a biochemical breakthrough, which is characterized by an ALT elevation. HBV resistance to NAs, that is patients' selection of HBV variants with amino acid substitutions that confer the reduced susceptibility to administered nucleoside analogs. In patients who discontinue nucleoside analog, serum HBV DNA less than 2000 for at least 12 months after the end of therapy. And there are different terminologies for treatment failure in peg interferon also. Again, virological response sustained off therapy, and serological response for envelope antigen and for the surface antigen. So recommendation is the long-term administration of a potent nucleoside analog with high barrier to resistance is the treatment of choice. So the preferred regimens nowadays clinically are entecavir, tenofovir alafenamide as monotherapies. Lamivudine, adifovir, and telbivudine are not recommended nowadays. So the monitoring is all patients with a nucleoside analog should be followed with periodical assessment of LFT and DNA, HBV DNA. Patients who are at risk of renal disease treated with any nucleoside analog, and all patients regardless of renal risk treated with tenofovir should undergo periodical renal monitoring like eGFR also. Patients who are at a risk of development of underlying renal or bone disease, they should be switched over to tenofovir alafenamide depending on the previous lamivudine exposure. So at baseline, we check for the full blood count, liver and kidney functions, DNA levels, and the eGFR. So tenofovir alafenamide dosage is 25 milligram until GFR is less than 15 ml per minute, and baseline renal risk is should be assessed for all patients, and there is a high renal risk which includes so like when the patients with decompensated cirrhosis, eGFR less than 60, poorly controlled blood pressures, proteinurias, uncontrolled sugars, active glomerulonephritis, and concomitant any nephrotoxic drugs or any solid organ transplantation, they have high renal risk. So during treatment, the liver function test is checked every 3 to 4 months and DNA for every 3 to 4 months. The surface antigen is checked every year. Monitor all chronic hepatitis B patients with tenofovir effects and who are at high renal risk undergoing any nucleoside therapy. We have to check the creatinine. So what are the indications for this entecavir or tenofovir alafenamide over TDF? So latest drugs we are using are entecavir and tenofovir alafenamide, mainly for age more than 60 years who have bone disease or any renal compromise. So what are the long-term outcome during NA, that is nucleoside analog, is a patient under effective long-term nucleoside analog should remain under surveillance for hepatocellular carcinoma. So the HCC surveillance is mandatory for all patients with cirrhosis as well as those with moderate to or high HCC risk at the onset of therapy. So discontinuation recommendation, the hepatitis B, we have started all treatments. So after is a confirmed H with or without any antibody formation. And nucleoside analogs can be discontinued in non-cirrhotic who are envelope antigen positive chronic HPV, who are any who complete at least 12 months therapy. Nucleoside analog is selected in selected non-cirrhotic HBeAg negative patients who have achieved long-term, that is more than 3 years, virological suppression under nucleoside analogs may be considered if there is a close post-nucleoside analog monitoring can be guaranteed. So management of this nucleoside analog failure recommendation, that is prevention of resistance, should rely on the use of first-line therapy and high barrier to resistance. So complaints to this therapy should be very important whether the patient is taking drugs properly. So the complaints to nucleoside analog therapy should be checked in all cases of treatment failure, and management should be based on the cross-resistance data. Treatment adaptation should be performed as soon as virological failure under nucleoside analog is confirmed. Primary non-responders, poor complaints, main cause. In a complaint patient with a primary non-response, then genotyping for identifying possible mutations will also help. Primary non-response is almost exclusively seen with mainly adifovir, and because the suboptimal antiviral potency, and that has to, we have to switch it over to tenofovir alafenamide. Then partial virological response will be, the importance in checking is when the patient who receive nucleoside analog with a low barrier to resistance, it is recommended to change to a more potent drug without any cross resistance. Most of the time, the partial virological response under entecavir and tenofovir, very high pre-treatment viral load. The most likely that could be because of very high pre-treatment viral load and not the result of the efficacy of the drug. In such patients with a partial virological response at week 48, the DNA levels at week 48 and their kinetics must be taken into account. In those with plateauing levels of HBV DNA, they can switch to other drug or a combination of entecavir with tenofovir and can be envisaged especially in patients with advanced liver disease. And there is a virological breakthrough mainly related to the drug resistance, and the treatment adaptation should be performed as soon as the viral breakthrough is identified and subsequent ALT elevation to prevent the progression. So management of antiviral drug resistance, that is risk of resistance is associated with high baseline DNA levels, a slow decline in DNA and previous suboptimal nucleoside analog treatment. So resistance should be identified And there is a pattern of resistant mutation should be used to adapt the treatment strategy. So the combination management of patients who develop a nucleoside analog resistance, or those who develop a resistance to lamivudine, switch to tenofovir. Those who develop resistance to telbivudine, again switch to tenofovir alafenamide. So most of the drug resistance, we have the rescue therapy with tenofovir alafenamide. And this when adifovir resistance is there, and if lamivudine naive, switch to entecavir. If lamivudine resistance, then switch to tenofovir. If tenofovir resistance is there, if a patient is again not introduced to lamivudine, then switch to entecavir. And when there is a multi-drug resistance noted, then switch to entecavir plus tenofovir. For chronic hepatitis B, it's considered as an initial treatment option for patients with mild to moderate infection. That is the evidence level 1. The standard duration of interferon therapy is 48 weeks. And the extension is beyond week 48 may be beneficial in selected cases who are HBeAg negative patients. And that is also a very low level of evidence. All chronic hepatitis B patients treated with interferon should be followed with, again, LFT, thyroid, DNA levels. And the serum HBV DNA and HBsAg levels in all the chronic hepatitis B patients. So this chronic hepatitis B patient should be checked at 3, 6, and 12 months of pegylated interferon treatment, and at 6 to 12 months post-treatment also. So in patients with undetectable HBV DNA, peg interferon response and stopping rules in HBeAg patients with chronic hepatitis B, when the viral load is more than 20,000 with genotype B and C, or no decline in surface antigen levels, at 12 weeks of peg interferon therapy, they have very low probability of subsequent seroconversion also. And also when in HBeAg positive chronic hepatitis B patients with genotype A to D, HBsAg level more than 20,000 at 24 weeks, are associated with very low probability of subsequent seroconversion. So we can stop this treatment for those patients. And in HBeAg negative chronic hepatitis B patients with genotype D, a combination of no increase in HBsAg levels and a less than 2 log reduction at 12 weeks therapy predicts no response and should be used for the stopping rules. So combination therapy, that is nucleoside, 2 nucleoside analogs combination. De novo combination therapy with 2 nucleoside analogs with high barrier to resistance, that is entecavir and tenofovir, is not recommended. In treatment adherent patients with incomplete suppression of replication, reaching a plateau during this therapy, that is entecavir or tenofovir long-term therapy, a switch to other drug combining both drugs may be considered. So nucleoside analog plus peg interferon. The recommendations are de novo combination of nucleoside analogs and peg interferon. The de novo is not recommended. In that is a HBeAg positive patient treatment. Short-term pre-treatment with a nucleoside analog before peg interferon is not recommended. And in long-term nucleoside analog suppressed chronic HBV patients, adding interferon or switching to peg interferon is not recommended. So treatment of patients with decompensated cirrhosis with the nucleoside analog with high barrier to resistance. So their peg interferon is contraindicated in decompensated cirrhosis. Straight away, we have to start them on analogs. So patients should be monitored for tolerability of drugs and development of rare side effects like lactic acidosis and kidney dysfunction. Prevention of recurrence after transplantation. All patients on transplant waiting list with hepatitis B related liver disease should be treated with nucleoside analogs. So combination of hepatitis B immunoglobulin and a potent NA is recommended after transplant for prevention of. Patients can discontinue the immunoglobulins but need to monoprophylaxis with an antiviral, that is a nucleoside analogs. HBsAg negative patients receiving livers from donors with evidence of past infection are at risk of recurrence and should receive antiviral prophylaxis. Special groups co-infected, HIV co-infected patients, all HIV positive patients with hepatitis B co-infection should be started on antiretroviral therapy irrespective of the CD4 count. Whatever the CD4 count, first start ART. Then HIV, HBV co-infected be treated with a tenofovir alafenamide based regimen also. HDV, that is hepatitis D co-infected patients, peg interferon A for 48 weeks in the current treatment of choice, and in hepatitis B and D co-infected patients. So these patients with ongoing replication, the nucleoside analog therapy should be considered. Peg interferon is continued until 48 weeks, irrespective of the response. Interferon A, only available drug that has been proven to have some antiviral efficacy against hepatitis D infection. So studies applying peg interferon A showed on treatment virological response rates in 17 to 47%. And long-term RNA monitoring is recommended for all. HbSAg loss may develop in long-term follow-up in approximately 10% of peg interferon A patients and can be taken as a marker of cure from HIV. Hepatitis B. So patients fulfilling the standard criteria of hepatitis B treatment should receive new treatment also. HbSAg positive patients undergoing DAA therapy should be considered for concomitant nucleoside analog prophylaxis until week 12 and has to be monitored closely. HbSAg negative with core positive patients undergoing directly acting antiviral therapy should be monitored and tested for in case of SGPT elevation. Acute hepatitis B, more than 9% of adults with acute hepatitis B do not require specific treatment at all because they will fully recover spontaneously, acute hepatitis B. So only patients with severe acute hepatitis B, those who present with an acute liver failure characterized by coagulopathy and encephalopathy, and those who have a protracted course, they should be treated with nucleoside analog and considered for liver transplantation. So characteristic of acute hepatitis B are coagulopathy with INR of more than 1.5, protracted course, that is symptoms are marked jaundice for more than 4 weeks, and when they have signs of acute liver failure. Early antiviral therapy with highly potent nucleoside analog can prevent the progression of acute liver failure and subsequent liver transplantation and mortality. So this effect is not seen if antiviral therapy is initiated late in the course. So if except for severe acute hepatitis B, there is no role in routine acute hepatitis B. They resolve spontaneously in 95%, so need not treat. So data in ALF situation, there is acute liver failure and severe acute hepatitis, then it is indicated the use of tenofovir and entecavir or even lamivudine. So early nucleoside analog treatment does not increase the risk of chronicity. Coming to the children population, the course of disease is generally mild and most of the children do not meet standard treatment indication, and thus treatment should be considered with caution. In children or adolescents who meet the treatment criteria, then entecavir or tenofovir or peg interferon can be used. Pregnancy, screening for HbSAg in the first trimester of pregnancy is strongly recommended. In a woman of childbearing age without any fibrosis who plans a pregnancy in the near future, it may be prudent to delay the therapy until the child is born. And any pregnant patient, women with chronic hepatitis B and advanced fibrosis or cirrhosis, then therapy is recommended. In a pregnant woman already on nucleoside analog therapy who is becoming pregnant, then TDF should be discontinued while entecavir or other nucleoside analog can be switched over. In all pregnant women with high DNA more than 2 lakhs or HbSAg level more than 4 logs, then antiviral prophylaxis should be started at the 7th month, beginning of 7th month, 24 to 28 weeks, 6th to 7th month, and then continued up to 12 weeks after delivery. Breastfeeding is not contraindicated in HbSAg positive untreated women or tenofovir based treatment or prophylaxis. Healthcare workers, HBV infection alone should not disqualify infected persons from practice or study of surgery, dentistry, medicine, or allied health fields. Health workers performing exposure prone procedures with serum HBV DNA more than 200 may be treated with the nucleoside analog to reduce the transmission risk. And patients undergoing immunosuppressive therapy or a chemotherapy, all candidates for chemotherapy and immunosuppressive therapy should be tested for occult B. Not only HbSAg, DNA, they have to be checked for IgM anti-HB core antibody because they are already on immunosuppression. So all HbSAg patients should receive entecavir or tenofovir alafenamide as a treatment prophylaxis. And HbSAg negative anti-HBC positive subjects should receive prophylaxis if they are at a high risk of reactivation. Then patients on dialysis and renal transplant patients, all dialysis and renal transplant recipients should be considered for screening. If they are a dialysis patient, they require treatment entecavir or tenofovir. All HbA1c positive renal transplant recipients should receive entecavir as a prophylaxis. And surface antigen negative, core positive, that is occult B positive subject should be monitored for HPV infection after transplantation. And when patient presents with some extrahepatic manifestations, patients with replicative HPV infections and they have to be straight away started for with so the idea for presenting viral hepatitis B and C today in this forum is mainly both are preventable and controllable. Mainly hepatitis C is completely curable because it has a dreadful complications like cirrhosis, hepatocellular carcinoma, different severe decompensation, and a lot of complications. So this can be avoided by a simple antiviral drug which is used for 12 weeks, oral antiviral drugs which is available even in the government setup. And hepatitis B awareness to all our patients and patients' family also is important. Very important. The HbA1c affected individuals and the family has to be screened and vaccinated if they are surface antigen negative. By preventing this infection in the initial stage, we can prevent a lot of complications which runs in families also because it is a bloodborne. So to create awareness and to discuss about the various treatment options and recommendations, I specifically presented this topic today. I'll be happy to answer any queries. Thank you for the opportunity, sir. Thank you.
Ma'am, for this wonderful elaborate presentation on the viral hepatitis to mark the World Hepatitis Day. Thank you very much. Thank you, Dr. Alprakash sir, for the wonderful moderation and topic introduction and speaker introduction. And I thank the stem cell therapist specialist, Dr. Ravi sir from the hospital Trichy, and Dr. Rajkumar sir. So they're all leading stalwarts in stem cell therapy, regenerative medicine. We'll be starting IMA-AMS fellowship course very shortly, already applied. We are waiting for the approval from the IMA headquarters. So we'll do all the good things. So the futuristic medicine will be the AI with the stem cell therapy, regenerative medicine from head to foot. All the departments you can take from the neurodegenerative, orthopedic, vascular, urology, skin, diabetology, retina, eye, ophthalmology. There are various indications. So this is a very, very major role to prevent unnecessary complications, crippling, etc. So thank you, Ravi sir, Rajkumar sir, for a wonderful update and highlight. We'll do frequent meetings, frequent update to create awareness among our own colleagues, first of all. So thank you all. So thank you all delegates for this wonderful participation. I thank you, my chairman, Rajesh Babu sir, and our IMA president, Dr. Abul sir, for all the leaders, all the delegates of IMA family. Thank you very much.